Good morning friends, welcome to my channel Pediatric classes. It's a while since I've uploaded a video because I got held up with some of my research works. So let's discuss today the question paper of the previous university exam. That is a Kuha's university exam pediatric paper. Okay, I'll just read out the question. A 5-year-old male child presented with edema around eyes which progressed to generalized edema in a few days. He had normal urine output. The urine examination showed heavy proteinuria but not hematuria. What's your probable diagnosis? That is the first question, carrying a mark of 1 mark. So this is an essay question. We have many subtypes. Okay, so once you ask the diagnosis, you can write, then you will write as nephrotic syndrome, but you have to write as first episode because there are no previous episodes history mentioned. Pathogenesis, we need the pathogenesis, why edema is there, why proteinuria is there, and why hypercholesterolemia is there. So just don't write only about the albuminuria part. Okay, so the way you should go is you should say that the most of the cases are actually idiopathic, which are around 10% cases are secondary cases. Okay, this effacement of the food processes of the podocytes. Okay, so once there is effacement, what happens? There is leakage of proteins. Once there is leakage of proteins, this will lead to massive hypoalbuminuria and later hypoalbuminemia in the baby's body. So what's the hypoalbuminemia? What happens? That is, there is actually a decrease in the balance. In one of the videos I've told you, there is a balance between the hydrostatic pressure and the oncotic pressure, which actually maintains the fluid balance in our body. So that balance is disrupted. So what happens? There is leakage of fluid outside into the interstitium. There is edema. So that is the pathogenesis of edema, and you will underline that edema part also. Okay. Now that will carry that pathogenesis. The whole thing is for actually 3 marks. Okay, 3 marks now. Let me say, yeah, pathogenesis of this one is 3 marks. So once you write the certain cases are primary, certain cases secondary, and give a few causes of secondary diseases like Hodgkin's lymphoma, vasculitis, SLE, drugs, etc., you will get 1 marks. Then you will explain in detail about the pathogenesis of edema. That will carry another 1 mark. Then we also have to tell why there is actually hypercholesterolemia. And so what happens? One another thing is, once there is edema, that will stimulate the renin-angiotensin-aldosterone mechanism. Later, and antidiuretic hormone secretion later will be enhanced, and later all this will go for sodium and water retention. That also will cause edema. So edema full pathogens you have to explain. Okay. Now also this hypoalbuminemia will cause hepatic synthesis of lipoproteins that will go and create a hypercholesterolemia in the baby's body or the child's body. Now we can actually say about this and finish off the pathogenesis. That is done. Now this is down to essential investigation. Definitely, see, please write urine analysis as the first investigation. You will write that it is around 3+ to 4+ albuminuria we are expecting there. Then occasionally we say that then you have to write urine protein by creat ratio of more than 2. 24-hour urine protein we can check, and it is more than 40 milligram per meter square per hour, or 1 gram per meter square per day. Then the second investigation is blood urea creatinine, which is really normal. We will see the serum albumin, which will be less than 2.5 gram per deciliter, and serum cholesterol, which will be more than 200 milligram per deciliter. Coming to the complete blood counts, we can do it to rule out any infections, and also a tuberculin test and Mando. Before we start the steroids, we have to rule out a tuberculosis in any case of suspected nephrotic syndrome. Then, depending on the clinical lab findings and other lab findings, we can actually order for additional tests. That additional tests will come later, like for example C3. If there is gross or microscopic hematuria is noted and if it is persisting, you can ask for hepatitis B surface antigen, ANA titers and anti-DS DNA titers. This is all to rule out the secondary causes of nephrotic syndrome. Then even a renal biopsy if the patient is not fitting with the correct standard picture of the nephrotic syndromes. Okay, so there are many things. So that all will carry another 3 marks. So then how will you manage a child in this hospital is another question. So kindly refrain yourself from just writing steroids. No, the way it should go is, it is a 3-mark question. So 1 mark is exclusively for the general measures. You will say, I will advise a high protein diet. You will say that a normal balanced diet the patient should have with no added salt. Any infection is there associated means you should treat it. We have to check the daily weight, BP, height, and vitals regularly. Suppose the patient is having ascites also associated, you can actually check the abdominal girth. Okay, so the general measures, then diuretics are administered not in all cases, but only if the edema is very significant. That what we should be careful is the dosage of furosemide and is 1 to 4 mg per kg per day in 2 divided doses, or with or without an aldosterone antagonist like spironolactone 2 to 3 mg per kg per day in 2 divided doses. Okay, specific therapy will carry 1 dose. So first is the general measures, then the use of steroids you told. Now then you are telling about the specific therapy, that is our oral prednisolone. It is 60 milligram per meter square per day or 2 mg per kg per day. Okay, please not make a mistake there. In single or divided doses for 6 weeks. That is the initial part. Then followed by we give 40 milligram per meter square per day, or actually this meter square per day is better. So we always say that it is 60 mg, or later it is to be followed up by another 40 mg per meter square per day. So that will come around 1.5 mg per kg per day. Okay, so that is to be given on alternate days for 6 weeks. Single morning dose. Okay, so I hope you are clear about this dosage. Please write it down in the notebook, read it clearly, because there's a chance that you may make a mistake with the units. Okay, now the third part which carries 1 mark is the parent education part. So anybody asks you the treatment of prednisolone, you will write general measures, you will write the specific treatment, and then you will write the parent education part, where you actually discuss with the parent about the disease, about the outcome, the cooperation we have to tell. Then only you will get the full cooperation of the parents in the treating of this disease. And we should also teach them how they can examine the urine for protein, and what they should do if they see a positive result. They should immediately revert back, and they should actually tell them the need for regular medications and also regular follow-up. If there is any infections, they should report back, and also the danger signs should be told. So that will carry the whole thing. When I see that will be around 1 plus 3 plus 3 plus 3 mark, it is 10 mark question. Coming to the next question, that is a short note. That is about the clinical features and management of acute watery diarrhea with dehydration. The question modified as some dehydration. In that OP guide, that one tabular column, that look, assess, feel, that is a very useful table. You can actually put that table up there, or you can just write it. What you see, how is the general condition of the patient. So you will tell that general condition in the some dehydration will be restless, irritable, eyes will be sunken, tears will be absent, mouth and tongue are dry, thirst. Okay, the patient will be thirsty and will drink eagerly. And what do you feel about the skin pinch? Skin pinch goes back slowly, and you decide that the patient is having some dehydration. Followed by what will you give the treatment? Again, this question has been getting repeated so often. So here the decision is we have to replace the deficit. Number one thing that will carry 1 mark. Then that is the plan B. Okay, as you know, it is 75 ml per kg over 4 hours. That much ORS we will give over 4 hours. If the child is not able to drink orally, you can give us an nasogastric way, you can give that. And after 4 hours you assess, and then you decide whether the child will continue in plan B or go to plan A or go to plan C accordingly. So this is about the replacement of deficit. Next is the treatment of ongoing losses. The child will be passing on stools, no? That will carry half mark. So it is 10 ml per kg per stool. For every stool the child passes, we will give 10 ml per kg of ORS. And maintenance daily requirement. This also in the previous videos we have discussed. As you know, according to the holiday Segas formula, up to first 10 kg it is 100 ml per kg. Beyond 10 to 20 it is 1000 plus 50 ml per kg for every kg beyond 10 kg, and beyond 20 kg it is 1500 plus 20 ml per kg for every kg beyond 20 kg. So accordingly you give the maintenance. So this answer will have 3 parts. One part you will discuss what are the features. Second part is the treatment. Treatment part you will tell about the replacement of the deficit, treatment of the ongoing losses, and other supportive measures. Now the next question, that is about the microcephaly. The 1 mark out of the 3 marks, the 1 mark is for the definition. Okay, what is the definition? Definition is like if the head circumference is less than 3 standard deviation. I repeat again, underline it. It is less than 3 minus 3 standard deviation. If the point plotting is less than minus 3 standard deviation, then we will say that this child is having a microcephaly. that will carry 1 mark. What are the causes? Again you will write as 2 things. One is the primary microcephaly. It can be inherited as autosomal dominant, recessive manner, etc. as in Downs, Edwards, Cradushat, etc. Or it can be secondary or non-genetic microcephaly. So all these intrauterine infections like CMV, toxoplasma, all those things, infections you can write about fetal alcohol syndrome, radiation, Hagen-Dazn syndrome, etc. etc. So you will give a few causes regarding that. You will actually write what are the clinical features. What is the clinical features in a case of microcephaly? As you know, there will be a receding forehead, there will be overriding of clinical switches, and if you do, the head circumference will be less, and there is maybe intellectual disability. Then investigation also carries half. Please don't forget to write that. You can write as karyotyping, TOR screening, MRI, metabolic screening, etc. So microcephaly, now I hope you are clear about how to write an answer for microcephaly to get 3 marks out of 3. Now next question is about the Staphylococcal pneumonia, the question number 4. So here we will write, what is Staphylococcal pneumonia? It is the primary infection of the parenchyma, or either primary infection or secondary to the septicemia of Staphylococcus in the body. So predisposing factors for Staphylococcal pneumonia are measles, influenza, cystic fibrosis, malnutrition, diabetes mellitus, etc. etc. So this will carry half marks. The rest will be it is a suppurative bronchopneumonia resulting in a bronchoalveolar dissection. Multiple micro abscesses are formed. Then that is the pathogenesis you will explain in another half mark. Then what happens that micro abscess will erode the bronchial wall, that will discharge the contents into the bronchi. This air enters the abscess cavity during inspiration. Progressive inflation results in the formation of pneumatocysts. So you are explaining here about the formation of pneumatocysts also. Then another 1 mark is for the complications. So the complications include staphylococcal lung abscess. This may erode into the pericardium causing a pyopericarditis, or into the pleural cavity it may erode to cause empyema. So there is a risk of pericarditis, there is a risk of empyema. Other complications like pneumothorax, bronchopleural fistula, pyopericardium, etc. It may be associated with disseminated disease with joints abscesses. Okay, this abscess can form in joints or in the pericardium, liver, etc. etc. So what is the treatment? Very important question. It can come as a 1 mark question also. So don't forget this. Again, general measures. We have to hydrate the patient. You have to give antibiotics, oxygen therapy if there is a desaturation noted, and this staphylococcal antibiotics has to be given for 3 weeks. You will write about the name and also the duration. Please note here, the drug of choice is IV cloxacillin for community acquired pneumonia, and if it is not responding or if it is a hospital acquired, you may have to shift up to vancomycin or linezolid for hospital acquired infections. Another choices are co-amoxiclav and also teicoplanin. So all that will carry another 1 mark. So this is how the division. I am repeating again about the division of marks, because many times if you write only pathogenesis, how much ever you write, you will get only 1 marks or a half mark to 1 marks. Okay, so we have to include all these points. So that is that. Next is the 5th question, that is about the components of the that's a very important question, another one. So first you will write about what are the components. So the classic tetrad of tetralogy of Fallot is a large VSC, there is an overriding of the aorta, there is a pulmonary stenosis for infundibular stenosis, and an RVH. So that is a triad. So we can actually draw the diagram. Pulmonary stenosis will cause that concentric right ventricular hypertrophy, or RV pressure becomes as high as the left ventricular pressure. What happens is the shunt, the right to left shunt occurs, and the severity increases with the severity of pulmonary stenosis. Okay, I hope you are clear there. Please refer back to the video on top for a detailed explanation of about the pathogenesis. As the systolic pressure becomes identical, what happens that the VSD, the shunt disappears, there is no murmur also. The intensity of murmurs varies inversely with the severity of the PS. Then another thing is we have to tell is there is a single S2, that is the A2, which actually we are hearing, and the ascending aorta is really large and will cause an aortic ejection click. So that's it about the 4th question. And coming to the 6th question, that is WHO classification of vitamin A deficiency. Very, very important question, very easy to score. You just have to remember X1A, that is conjunctival cirrhosis. Many times when we were evaluating, we found that the students were writing corneal cirrhosis. Please don't make that mistake. That is 1A, that is conjunctival cirrhosis. Then X1B, that is white hot spot. X2, that is the corneal cirrhosis. X3A and 3B is there. 3A is corneal ulceration less than 1/3 of the cornea, and 3B will be more, it is more severe. So it is a corneal ulceration involving more than 1/3 of the cornea. Okay, coming to the secondary, these are the primary signs. Secondary sign is XN, night blindness, XF, fundal changes, and XS, that is the corneal scarring. Coming to the 7th question, that is about the proper positioning during breastfeeding. Here please note, this is a 2-mark question. You have to write about the position of the mother and also about the position of the baby. The position of the mother, the baby and the mother. Baby, as you know, the baby should be wrapped in a proper cloth. The baby's whole body should be supported. Head and body should be in one single plane. Then baby's body turned towards the mother in such a way that the abdomen touches the mother's body, and baby's nose is at the level of the nipple and the mouth is everted. So about the position of the mother can actually assume any position that is comfortable to her and the baby, though the preferable position is in a sitting position. She can lie or sit or lie down. Her back should be well supported and she should not be leaning forward. Once the baby starts suckling, we should make sure that the baby is latching at the breast properly. The 8th question is about the rotaviral question, a very favorite question of examiners. So here you will write that what are the types of oral, what type of vaccine it is. So it is a live attenuated oral vaccines. 2 types are available. One is a monovalent type, that is a Rotarix, and or pentavalent types are also available, that is a Rotatec. Okay. So whatever it is, what is it used? It is used to prevent infectious diarrhea due to rotavirus. So we are actually recommending this in our national immunization schedule also. The schedule you will write, that is 6, 10 and 14 weeks. And you please remember here, when you write that route of administration should be mentioned clearly, that is oral. The storage is at minus 20 degrees Celsius. Contraindication is any anaphylaxis after the previous dose. And a history of intussusception in the past or a severe combined immunodeficiency will come as the contraindications. Okay. And about the dosage, it is 0.5 ml or 5 drops for the monovalent vaccine and 2.5 ml for our bovine pentavalent vaccines. Clear? Now, certain brands like Rotaris, we need to give only 2 doses. But most of the recommended schedule is vaccines are we are giving and 3-dose schedule of 6, 10 and 14. So coming to the next question, that is the antenatal diagnosis of Down syndrome. Again here, it's a 2-mark question. You have to divide it as ultrasound finding and also the maternal serum markers. So ultrasound finding, what are the things you get? One is the increased nuchal translucency. You will get the absence of absence or even a short nasal bone. The findings in the 2nd trimester which suggest Down syndrome are again increased nuchal fold thickness, short femur and humerus length, and also duodenal atresia. So these points, once you write all these points, definitely you will get 1 mark. And another about the maternal serum biomarkers. So there is an estimation in the 1st trimester. What we do is the pregnancy associated plasma protein A and the free human chorionic gonadotropin HCG in the 1st trimester. And another thing is about the triple test, that is alpha fetoprotein, beta HCG and unconjugated estriol, and that is the triple test. Along with it, if you add inhibin A, that will cause quadruple test. Okay. Please note, alpha fetoprotein, estriol are low, whereas HCG and inhibin are high. How I remember is HCG and inhibin, no, H is there, inhibin I is there, so they are, the values are high range, because sometimes we get confused which goes high, which goes less and all that. So please note, HI, HCG, inhibin both are high. Okay. Then we can also get a prenatal diagnosis by fetal karyotype by either a coronicular sampling or an amniocentesis. Now the question, 10th question, that is WIFS. My goodness, so many people made a mistakes of this question because this is not a common question. WIFS is a weekly iron and folic acid supplementation launched by the Ministry of Health and Family Welfare. Okay, why they have launched it is because that is to circumvent the problem of high prevalence and incidence of anemia among adolescent girls and boys in both rural and urban areas. So this program is actually enrolled not only in states but also in union territories. This covers around 11.2 crore beneficiaries. including 8.4 crore in school and 2.458 crore out of the school. Okay, so objective is you have to give weekly iron and folic acid. Thus, target groups are all the school going adolescent girls and boys in 6th to 12th standard, enrolled in government or government aided schools, and even out of the school adolescent girls are also included. So what do? Intervention is iron folic acid supplementation of 100 milligram of elemental iron and 500 microgram of folic acid every week. They are using a fixed day approach. Screening of target groups for moderate to severe anemia and referring these cases to appropriate health facility is also an intervention under there. And they also have biannual deworming with using albendazole 6 months apart for the control of helminthic infection. Along with it, we are actually giving a counseling and also information regarding the proper dietary intake for taking regarding all this prevention of anemia. Okay, so now the 11th and the 12th question I will discuss at the end because I have to show you how to draw them. So 11th and 12th we will discuss at the end. Now coming to the one-word answers. This time the one-word answers were relatively good questions. Commonest type of muscular dystrophy in children and its mode of inheritance. An easy question it was. So it is Duchenne's muscular dystrophy and X-linked recessive inheritance. Next is the dosage and duration of zinc supplementation in a 1-year-old child with diarrhea. Again, very good question. Only two things are there. More than 6 months, it is 20 milligram OD for 2 weeks. Whereas less than 6 months, it is 10 milligram OD for 2 weeks. Here the question is for a 1-year-old child. So obviously the answer is 20 milligram of zinc OD for 2 weeks. Okay. Next is the cause of hemorrhagic disease of newborn. Here the expected, the most common classic HDN, that is hemorrhagic disease of newborn caused by vitamin K deficiency is the answer for that. One indication for IVIG, write ITP, GBS, that is the Guillain-Barré syndrome. You can write any immunoglobulin deficiencies. Then even certain diseases like varicella and measles and all, for prevention purpose also we use this. So there are number of indications for IVIG. At least 2 you write, you get the marks. So this is about the draw and label question. That is question number 11. Growth of different tissues and organs in children. Please note this is a very important question. So this is first one, if you see, that is the brain growth. As you can see, the brain grows maximum up to the age of 2 years. Thereafter it does not grow and it remains stagnant. Somatic growth, see, there are 2 spurts mainly you can see. One is towards the puberty and one is the initial childhood time. And what about the lymphoid growth? 4 to 8 years, the maximum growth is there, and the gonadal growth by around 12-13, once the puberty starts, the gonadal growth happens. So this diagram, the reference is the OP guy only. Actually, I have taken it from here. I'm not sure whether the clarity is there or not. So kindly excuse if the clarity is less, okay? So coming to the next question, that is the 12th question, prolactin reflex. This diagram is also from OP guy. So this we have to draw. It may not be as beautiful as this, but you can draw once. You just have to show that the baby is suckling at the breast. This will send sensory impulses from the nipple to the anterior pituitary. Okay. So the reflexes are sent to the anterior pituitary, which will release the prolactin. This prolactin will cause or simulate the milk secretion. So similarly, this year they have asked prolactin, next year they may ask oxytocin, means you have to draw this diagram. Oxytocin reflex is another one reflex. Prolactin is secreted after feed to produce an X feed, whereas oxytocin works before or during the feed to cause milk flow. So prolactin is milk for milk secretion, whereas oxytocin is for milk ejection. Okay, it's given page number 146 of OP guide. So I hope you are clear about the question paper discussion. So certain question papers you also always have to go through because the questions get repeated in subsequent years. Okay, so kindly do subscribe and support the initiative. Thank you so much and stay safe.